Just,
You know what?
you're okay.
That's fine. I stand. Oh, there's more people than I have.
OK. Donc, on peut y aller. Bonjour, je m'appelle Éric Racine, je suis directeur de l'unité de recherche en éthique pragmatique de la santé, ici professeur à l'Institut de recherche clinique de Montréal. This short intro to the series will be in French, but I'll introduce our speaker in English in a minute. Mes collègues de l'IRCM, Aline Bogossian, Marjorie Montreuil, Corinne Lajoie et Amélie Ferrand, qui ne peut pas être ici avec nous, ainsi que les responsables des programmes en éthique clinique de l'Université de Montréal, sommes absolument ravis de vous accueillir pour un premier séminaire d'une série de séminaires en éthique de la santé. Le but de cette série mensuelle est de réunir autour de différents sujets en éthique de la santé. Notre objectif commun est de promouvoir l'éthique à travers un dialogue qui implique différents acteurs. Et vous allez voir dans la série, on va avoir des cliniciens, des patients, des chercheurs qui vont venir présenter à tour de rôle. Comme vous l'avez remarqué, le thème de notre série cette année, une série de 7 séminaires, est la sensibilité morale, ou ce qu'on appelle en anglais moral awareness ou moral sensitivity. Nos conférenciers et conférencières vont s'attaquer à des questions comme quels sont les mécanismes sociaux et psychologiques de la sensibilité morale, comment pouvons-nous même cultiver cette forme de sensibilité? Est-ce que c'est inné? Est-ce qu'on peut la cultiver? Comment pouvons-nous répondre aux signes de détresse morale lorsqu'on ressent des problèmes à connotation morale? Et quelles sont nos responsabilités personnelles, sociales, institutionnelles face à la sensibilité, ou peut-être plus important, à l'insensibilité morale dans nos institutions, dans nos contextes de travail? Donc, tout au long de la série, il vous sera possible d'assister à une seule conférence individuelle, mais nous avons choisi d'approfondir un thème cette année pour offrir la possibilité d'inscrire la série dans une réflexion de plus longue haleine pour les participants qui souhaitent le faire. Les séminaires webinaires auront lieu le jeudi à midi sur une base mensuelle. Les conférences sont évidemment gratuites, ne requièrent pas d'inscription. Vous pouvez vous joindre à nous en personne. Il y a quelques personnes ici à l'IRCM, aussi en ligne via notre page YouTube. Et en fait, toutes les conférences sont diffusées en direct. Vous allez pouvoir aussi les consulter en archive sur notre site Internet, qui est le www.pragmatichealthethics.ca. Et je veux mentionner aussi que vous pouvez nous rejoindre par courriel à pragmatic.health.ethics@ircm.qc.ca si vous avez des questions lors des séminaires, après les séminaires, et aussi vous allez effectivement pouvoir correspondre avec nous via cette adresse courriel. Et vous allez, ce que je voulais dire, vous allez pouvoir aussi soumettre vos questions via le canal YouTube ou bien via courriel. Nous allons recueillir des questions en ligne à la toute fin. On est dans une grande salle, on est un petit groupe, on est dans une grande salle parce que c'est notre seule salle à l'IRCM qui est équipée pour faire ce type de conférence-là. Donc, je vais vous inviter à partager l'invitation si vous aimez cette première conférence, à le partager avec des collègues, avec d'autres, à nous faire des suggestions aussi pour l'améliorer, comme c'est un projet pilote pour cette année. It is now my pleasure to introduce our inaugural speaker for this series, Dr. Kathryn Weaver. Dr. Weaver is professor at the Faculty of Nursing at the University of New Brunswick in Fredericton. She holds a PhD in nursing from the University of Alberta. She undertook postdoctoral training with the support of the CIHR EQUIP program at the International Institute for Qualitative Methodology and also in collaboration with the Alberta Heritage Foundation for Medical Research, also at the University of Alberta. Dr. Weaver is a recognized leader in nursing and ethics who has received several awards and recognitions for her teaching excellence, her research and scholarship, her engagement, and also for her clinical practice. Importantly for us today, she has published some of the landmark papers, in my eyes, on moral awareness and moral sensitivity. And before setting the podium to Kathryn, I would like to mention 2 papers which could be of interest to you. One of them is Ethical Sensitivity, State of Knowledge and Needs for Further Research, published in Nursing Ethics in 2007, as well as another paper published in 2006 called Pragmatic Utility Using Analytical Questions to Explore the Concept of Ethical Sensitivity. So without further ado, the stage is yours, and thank you again for accepting the invitation.
Thank you, and it is a total delight to be here to share some of the research that I've been engaged with. I thought I would likely start by disclosing how much of an imposter I sometimes feel. I didn't wake up and always want to study ethics. The need to learn ethics arose from my program of research, which was understanding why people, or how people recovered from eating disorders. And that was a burning desire, and the biggest barrier to their recovery, as identified through the interviews that I did, was that health professionals just weren't sensitive to them. And when I analyzed the meat of what they were saying, there were a lot of ethical violations. So by hook or crook, I got into the field and haven't stopped. I hope that I don't talk too fast or too slow. You can tell me, but this is such an important topic, and I am just delighted that we're starting with it. Yeah. Yes, I brought Socrates and Plato. And these dead white guys are wonderful. 2.5 centuries ago, it was Socrates who said, yes, ethics, it can be taught. It's, knowing what we ought to do in a situation. I kind of like Plato's interpretation a little better. Plato said, well, the aim of all education is to develop moral character so we can have a virtuous society. And he also felt that students needed to be immersed in quagmires and issues so that they would be exposed to them, so they would build the capacity to respond to new situations. So in my field of preparing nurses for the future, and I teach in an interdisciplinary course too, so I have quite a few med students in that course. So in that capacity, they need to be prepared to manage the ethical issues that they face in practice and in research. Kind of frightened by this. Just a sec. We'll try this one. Okay, so to get started, in recognizing and responsively addressing these ethical issues in nursing education, several research projects explored the experiences of nursing educators, nursing students with ethical situations in the context of their classroom and clinical teaching and learning. And as expected, the findings contribute to our knowledge of ethical sensitivity. And that's a leadership attribute. And it's based in self-awareness, foresight, knowledge of codes for ethical conduct, experience, and courage, which together enable intelligent and compassionate decision-making and amid the uncertainty of the situation. Oops, sorry. I'm not quite sure if Oh, okay, sorry. I'm going to talk a little bit about 3 studies that fall into the ethical sensitivity program, but I'm really going to focus on the middle one. Initially, I did a critical appraisal of the literature and analyzed at least 200 articles to understand that concept, and then worked with a concept clarifier to clarify this concept. And that study is also published. And at the end of the presentation, I have some references listed, so you can, if you're interested, you can follow up on any of those articles. Okay. I didn't conduct them, and I'll tell you why shortly. We did interviews with 24 nurse educators in the province of New Brunswick. They were face-to-face or telephone. They were audio recorded and transcribed. 7 were in New Brunswick French, 15 were English, and 2 of the educators identified as being Indigenous nurse educators. So I used narrative inquiry to explore their experiences in developing their ethical sensitivity. I'm in an ongoing project now, and I'll share little highlights as relevant to the nurse educator story. It's a mixed method approach. I'm looking for 50 nursing students, and I have 42, actually, there were 46 responses since I prepared this a couple of days ago. So I'm going to meet that goal quite nicely. And I'm looking at the experiences of undergrads, ASP, that's our double degree program. Most universities have that. It means you don't need 4 years to get into nursing. If you already have a degree, then you can harness that information and then do the nursing component in 2 years. So they're involved, and I think so far 8 masters in nursing students have participated. I was fortunate to have contact with Kim Lutzen, a Swedish nurse researcher who developed the moral sensitivity questionnaire. And she developed it through qualitative work with psychiatrists and psychiatric nurses. And she gave me full permission to adapt it for a Canadian and a nursing student context. So I have the link. If there's questions sort of at the end about it, we can click on it. I can show you what the survey looks like, if that would help. And actually, the link we click on, we will most likely get some responses show up too, so you could actually see how that system works. Okay. It's not happening here. Okay. Anyway, I'll tell you what it says. I had full institutional ethics review for the interviews and the LIME survey, the online survey that I'm using with the students. And I went through the Nursing Association of New Brunswick to send the invitation letters out because I'm a nurse educator myself, and it was not even appropriate for me to do the interviews for that reason. So I was fortunate to have a bilingual graduate student who I trained in data security and collection. She was able to anonymize every interview, and I was so pleased to get the stories. And then I had the opportunity last weekend to present some preliminary findings, and some of the people in the room identified as having participated in this project. So it's had a little bit of that test, which is so important, I find, in our work. All right. Oh, sorry, it's coming now. Yeah, so some of the sample questions that were asked of the nurse educators and the nursing students were, could you identify one ethical issue from a clinical or classroom setting that stands out to you? For what reason does this issue stand out for you? And again, I'm going to focus on this second project. It's the nurse educator study. So I used a narrative approach, and that is supported by the foundations of constructivism, that belief that multiple realities exist, personal knowing that you can reflect and you can take that knowledge and be able to articulate it, and hermeneutic phenomenology, which is mostly in the interpreting of the data. Theoretical underpinnings of narrative method is the belief that telling a story about oneself involves telling a story about choice and action, which have integrally moral and ethical dimensions. So I drew from Connolly and Clendenning and Christine Martin MacDonald that let me focus on the unique and common characteristics of the nurse educators' experiences in their teaching practice. I examined the data for plots, subplots, and those are just the secondary side plots, and narrative threads. Those are just the pieces that come together. Sometimes they're not full themes, but the threads are wonderful because they'll focus the attention to the character. So it avoids that dryness that sometimes happens with research. Not that any of us would ever create dry research, right? So I analyzed the data for recurring and unique elements, the context, insights, and the meaning-making strategies. I used emplotment, and that's kind of like tacking back and forth the bits of pieces from all the stories to integrate these disconnected events and happenings in the individual interviews into a coherent whole in an appealing way, referred to by Emden as a core story and explained by Polkinghorne as sustaining the richness of participant experiences. So the narrative threads that jumped out were workplace environment, institutional hierarchies and values, nurse educator relationship with students, attending to student vulnerability cues, ethical sensitivity, dividing loyalties, challenge to ethical ideals, support and reflexivity as the way forward, self-transcendence, and phronesis. I'm going to explain each of these and give you the examples from the data. The workplace environment is fraught with uncertainty. It likely is for more than nurses, but these were my participants. They said, right action's not always evident, not always clear, it's gray zoned. And there was often limited preparation for that teaching role of the nurse educators. They're hired because they were good nurses. They were observed to give good, safe care, and it was assumed that they could teach because they could do it. And listening to their stories, I think we need to backpedal some of that when we hire people. Because they said that they were learning just the whole process of how to teach students, how to create learning assignments that match the student learning needs with client assignments, preparing the written clinical evaluations, and run post-conference discussions. And those would all be new things that we wouldn't have done before. So not only do we have to learn how to help the student to learn the skill, but we also have to learn how to do these other processes that are part of clinical education. And then, of course, the classroom. There's a whole other set of skills involved with taking on a classroom course and making sure you're conveying the content in a way that's helpful to the student. So they're busy and almost disadvantaged right from the start, or that was the sense that seemed to emerge. This is a busy slide because the workplace where the educators take their students is incredibly complex. And they're dealing with institutional hierarchies and values. And these are just a few examples, but I'm sure you'll see maybe your perspective in them as well. In terms of the hospital, sometimes they talk about a holistic approach, but when it comes right down to it, it's I'm the physician and this is what we're to do. There are also hierarchies and values in academia. Many of the instructors are hired just before a course will start, but they need the context to understand the bigger picture of how the course they're going to fit teaches into the curriculum framework and the student's total experience, and that piece is missing for them, so it makes it a little difficult. Complexity and bias within the nursing unit environments. It seems that each nursing unit has its own culture, and which impacts on the way that the unit nurses practice. And students who the participants described as little sponges and moldable will come back and say, well, on my floor, they tell me to do this, and on that floor, they tell you to do that. So it's sometimes a little difficult for the nurse educators to, sort out, and most of this stuff isn't even in a textbook. It's what they're doing on that floor. So a little bit of concern in terms of, am I really preparing them well for practice that is already has so many masters? There's a culture shift that some of the nurse educators talked about. And so that's, advanced technology, increased access to information, consumerism, and the shift to client-centered care. And as a result, they said everyone is so time crunched. The nursing workforce is being casualized, and that's particularly true in some of our nurse educator positions. They're hired just to teach a course, so they'll have to supplement often if they need full-time work to do other courses, to not so much do other courses as to do clinical practice as well. And one of the participants was talking that people were older on a unit when they retired sort of all at once. You ended up with a group of very inexperienced nurses looking after very complex mental health cases, which really wasn't in the best interest of clients. So that's a bit of the institutional hierarchies. The nurse-educator relationship with students. I really wish I could have heard the interviews because I think I would have heard the sparkle. It kind of shines when I'm reading it. They love to know the student, and they do that through forming a relationship with each student. They acknowledge the student may not want to share, but I have a good feel of what they come to me with. They also do love to teach. Now, their primary goal in teaching is public safety, okay? And that's forming competent students who always go for the well-being of the client. And one quote is that I love it when she's talking about the students, and I'm saying she, although there was one male nurse educator, and I don't know who that was in the pile, but it's easier for me to refer to the nurse educators as she. I love it when they say, You know, I use my therapeutic communication skills when I went to the hospital today. And I say, you didn't use them any other time? The teacher builds, this role takes over, doesn't it? And they see themselves almost as sounding boards when they're supporting and encouraging students. You know, I think that feeling that they're emotionally safe and cared about and worthwhile as human beings, I think that's the most important thing. They advocate for students. Sometimes students are denied access to some of the clinics by the staff, so the instructor has to go on site, check the policy, and usually get the student in. And then sometimes the student doesn't even want to go at that point because it's been such a hassle. They are teaching the students how to care, which is a very difficult task, especially when there are so many tasks that they need to do. You know, they're teaching bathing someone in a caring way rather than just rip the blankets off and wash, and we're all done and forget about that human being there. So they're trying to teach them how to engage the patients in everything that they do. Now, I use the term client because it's easier to keep one consistent term. So if I do slip with a patient, it's something that a nurse educator had said. The other aspect of the nurse educator role is building professional sensibility. Noticing, students who maybe are biting their nails. Is that nervous? Do you need to get something for it? Because you can't have your hands in your mouth and then go do something with one of your clients. And even beyond that, you're not a nurse just at work. It's 24/7 because of the image we project, manners, way of doing things. You're still a nurse if you're at a club and wearing a wet t-shirt on stage. Okay, so they're trying to prepare these nurses and protect their reputation. Okay, the students have varying levels of vulnerability cues. And in New Brunswick, I'm not sure what it is here, many of our students are the first person in their families who have gone to university. And the pressure to be successful is intense. You see it almost from day one with these students. The nurse educators identify that first-year students are the most vulnerable. It's the most difficult place to teach because it's all so new to students. The students are under tremendous financial pressure. I can't tell if any of you are students, and I won't diverge, but you can likely relate to some of this. Students are working to afford phones, which will allow them access to data to assist in providing care to their clients. But then the students are too busy to learn because they're too busy working. So they have to fit us into their work schedules. When students arrive with learning disabilities or it's detected at the university level, the nurse educators are struggling to accommodate these students because they're not really understanding what the accommodation needs to happen and what the learning disability might all be about. No one tells us how to help. My background is nursing, not education. There are cultural barriers, and we are attracting increased numbers of international students to our programs in New Brunswick, and knowing the culture is difficult, and sometimes just a student who has been raised to never challenge an authority figure is reluctant to tell maybe his or her side of a situation, of an issue that's happening. So the nurse educator is left not knowing as much as needed to address the situation properly. And we have our language barriers. I mean, even in New Brunswick, where we are a bilingual province, however, some of the nurse educators in Moncton who speak a more Acadian version of French are having a hard time being understood by others who have maybe been exposed to a Parisian or a Quebec style. So I see some nods. Yes, it makes it a little harder. And the nurse educators are worried about the moral distress of students because they didn't feel that we were putting enough ethics into the curriculum. And it does, unless there's not a course in nursing ethics in most of our nursing curriculums. I teach one through MUN, but it's not totally nursing, it's an interdisciplinary course. But so they're worried that they're in ethical dilemmas without recognizing that these are ethical situations, and they might be experiencing a lot of moral distress with some of the associated physical concerns of sleeplessness and anxiety. And it may affect their mental health or their emotional well-being. So the nurse educators wanted to be more proactive and put more supports in place for these students. And then again, the students see marks as the measure of their ability. And, my students in clinical were completely distracted, spending the whole day talking about their exam tomorrow in biology or physiology. They're so focused on passing that exam, they can't enjoy today because they're thinking of marks and marks and marks. So, key characteristics of ethical sensitivity enable recognition, understanding, upgrading, and evaluating in a situation. And there are 3 absolute essential components for ethical sensitivity to be happening. And they're in a circle because they can happen at any time. One can inform the other. You don't necessarily start with moral perception. I'm going to start with it now, though. And that moral perception, it's that sense that something's not quite right. There might be an ethical problem. And for some people, it's experienced as awakening the moral conscience, awakening the moral awareness. And some of them describe it almost as a jolt, like when if you are pregnant and you feel that baby kick for the first time, like they're describing that kind of awakening awareness in such detail as that. So once they are attuned and they realize, ooh, something's not quite right, then they start to particularize, and they're running back through their experience and what kind of issue is this? Oh, maybe it's a conflict of interest. They're trying to sort it out so they'll begin to be able to address it better. And in this study of nurse educators, some of the issues that they were able to talk about were conflicts of interest, dual role. Some of them were therapists as well as teaching students, and found that sometimes was a little bit hard. Just trying to think of practice issues like living wills and things are always contentious, and they were dealing with those things as well. But just confronting incivility in the workplace, and just, we don't all get on well with everyone, and they were struggling with some of those issues. Okay, so the second key characteristic of ethical sensitivity is affectivity, and that's that embodied response to the ethical issue. And it can be sleeplessness, it's nervousness, anxiety. There's something, it's a real moral energy that builds, and they need that energy to actually be able to address the situation, but it starts out as a real uncomfortable feeling. One of the nursing students said, I was heartbroken and I felt dirty over a situation that was happening. So you can just feel it gets into you. They call it the emotional, this is an emotional distress. It's not moral distress right now. They're feeling not well because something's happening, and it may be happening while they're still trying to figure out what it is. So it's mostly a state of uncomfortableness. They begin to try and gain perspective. They are interpreting, they're gathering as much information about the situation as they can, and from the people that would have the most stake in it. Maybe it's clients, maybe it's family members, maybe it's other care team members, and then they're going to try and interpret what is going on. By way of justifying, they will consult textbooks. They will sometimes consult a clinical ethicist if they're able to get someone, and their code of ethics. Okay, this is like a long process, but we're going to keep going. As they start to get a sense of the different perspectives, they're in a position of what I ended up calling dividing loyalties. And that's where they are striving to enact their public duty to enhance health and well-being and alleviate suffering over all these loyalties, demands of universities, practice colleagues, and students. Moral attention, when maintained on public welfare, can influence safe student practice. So that's their goal, and they are aiming to have the public cared for safely, and the discipline, offering fair examinations and just doing what they can to even promote the reputation of the discipline as well. However, when moral attention does get away from the public good, the nurse educator's ethical ideals are challenged and moral turmoil may ensue. And so it's only once that challenge hits, they have to side with the student. They don't feel well, or some feel uncomfortable even failing students just because of the demand to have more students in practice. You're likely like us, we're experiencing extreme nursing shortages, and we want more nurses turned out. However, that's not the way. If a student's not safe, so then they're kind of conflicted. Or the student will challenge a failing grade, and someone on the appeals committee who's not from nursing will say, oh, they're safe, and the student's back in. So you can see they're starting to get stressed. Oops. You know what, that's fine. The other piece, and I won't spend forever on this, mindful of the time with dividing loyalty, so much is going on at that time. There's the university priorities, and they feel the university is mostly concerned with tuition and the education of the student, but not the student's ability to practice. Because it's possible in nursing to get a degree after 2 or 4 years and then not have a license to practice nursing. You have to write a separate exam afterwards. The disciplinary demands, and we have a national exam that was adapted from an American standard exam. It's called the NCLEX, and anyway, our nurse educators in New Brunswick are in a bad way. New Brunswick did very well. It turns out the French piece did, because the exam was not properly translated. They've won one of their cases. Now it's being appealed because this shouldn't be happening like that. So it's, we are having some difficulty with this, and there are no resources in French for students in a French program to prepare for the NCLEX. There are many in English, so there's a lot of disparity. The academic colleagues too are sometimes report, you shouldn't give the students so many options. And remember, some of our nurse educators are not as highly prepared as they would like at the start. The practice colleagues, they're watching them. The nurse educators say this, oh, there's someone watching. I'll pull a student offside to have a conversation. And the ears prick up all around. People are interested in what's happening with the students and the instructor. And sometimes the staff don't believe that the instructor is showing the student how to do something the way the staff person would. And and sometimes it just takes too long. So it's a little bit of discomfort in working through these divided loyalties. And sometimes the nurse educators say that they would not raise an issue unless they absolutely have to, because they need to come back with a new group of students next term, and they want to try and keep relationships okay. In the classroom, there are reports that students were sometimes in civil, and sometimes they were accusing, you're making a judgment to me, I did that right, you weren't there, to the instructor. So it gets to be a nice mess. Now, the nurse educators define student failure as the most difficult issue, and they feel bad for the students who have spent all that time and money and energy into trying to get their degree and were not successful. Okay, it didn't show here. Let me try it again. Yeah, sorry. Okay, so we've got, that when they go into that bottom side and they feel that they are needing to side maybe with students and the institution, their ethical ideals are challenged. Remember, their whole goal and purpose is to make it safe for the public, promote their health and well-being, and alleviate suffering. And if they feel that there's an unsafety issue and something happens and they can't address it, they will develop what they call mostly as moral turmoil. It sounds a lot like the literature on moral distress, but again, it would be needing to tease that out. They don't like to call it distress because they're associating that with depression and needing to go on antidepressants and things. So that was just their take on it. It was interesting. It's not in the literature yet, but it's something I would like to pursue at some point. When it becomes moral turmoil or distress, They feel that they can't make a difference anymore, and sometimes they'll leave a position for that. They feel that the situation can't be fixed, so it's kind of futile, and that's, the height of the turmoil. And they feel that the institution can't bend with them, so there's no real way. They know what they need to do to take right action, and they still can't do it because the rules would prohibit that. Okay, so the way forward is reflection and support. And the reflection always brings you back to yourself because you wonder, did I handle it properly? Did I not? And reflection on practice helps the nurse educators to trust myself and make the decision that I know is right. They recommend regular daily reflecting to build that capacity to reflect on the fly. I'll talk about that in a little bit with the implications, or to reflect on practice while they're actually engaged in practice. So that's a critical piece, and I know most health disciplines do encourage practitioners to learn how to reflect. What the nurse educators said, though, was that they had to have support in order to act on the insight that was generated from the reflection. For example, one of the younger nurse educators thought that the weekly meetings they were having about students to discuss progress and things were bordering more on gossip, and wanted to address it. And after wrestling with herself, she brought it up at the next meeting. This was a she because of the way the quote went. Brought it up at the next meeting, and it was kind of glossed over and nobody paid attention to it. So she felt she couldn't take it further, and because she really feels that confidentiality is being violated. But without the support, she said, that's as far as I can get right now. And it's not just knowing your ethics, it's knowing your resources, how to reach out, how to be a leader, how to stand up and take your place. So, as I say, the key is reflection, but it needs to happen within that bubble of support for it to work. Reflection brings a new learning and knowledge of personal and professional values in the form of insight to the surface. And when there's that condition of feeling supported, the insight may be disclosed to others. Okay. Following that intense reflection is self-transcendence. And I'm just going to read this quote because it says everything that I could possibly say about it. But from the Greek term, trans is beyond, and ascendance means to climb. So it's they have all this information. They're climbing above the situation to get a much better understanding of what's happening. I'm definitely not the same person I was before I entered nursing. Not the same person when I finished my nursing degree, and certainly not the same person as when I finished my master's degree. I believe that my life experiences, along with my education, has helped me through some really tough times and has broadened my thoughts. There are just so many perspectives to take into consideration. That's what really matters. So realizing how small I am in a big world, and there's so many ways of doing things and so many walks of life that I don't understand. Even though I understand by reading about them, I've never lived them, and it's a very different experience. Taking that in consideration is really important. So through my education and even life experiences, I've grown. I grow and change every day. They feel that they're becoming a better nurse by being able to transcend the situation, and they're becoming a better person, and they're integrating those pieces. I'm more compassionate now, and it comes from me having addressed some of these issues. Okay, now it's Aristotle's time. We did Socrates and Plato, because what has emerged in this study, and it was what I found in the original concept clarification, which was kind of startling at that time, was that the combined outcomes of learning growth and self-transcendence contribute to the development of phronesis, or practical wisdom. And that's a resource that the nurse educators develop as they work through that process of responding, recognizing and responding to the ethical issue, and then they take the learning from that forward to the next new situation. So it's a virtue, and nurse educators strive to use what I know works. They're referring to their experience. One of them even said, I didn't read about this in a book, but I know this is how to do something. I know this is what works. So they know what works to respond to each question, each concern, each anxiety and each learning disability a student has. And that's what Aristotle calls phronesis, the knowledge of particulars. That's gained in experience with a true action component. So they said, I think there's always that negative aspect with ethical dilemmas, but there's also trying to figure out how to repair and get things back, and it can be very stressful, for sure. I think ethical dilemmas make me stronger. I think anything that can help you look at how you're doing things or how you're managing things or how you might wish to in the future, you can always grow from them. And I would say it's probably made me stronger. And they also say that you need the opportunity to exercise your leadership in order to develop it. And the outcome of compassion is shown through clients and colleagues feeling safe, comfortable, and cared about. Whether they thought I made the right decision or not, I made sure to connect with them in terms of my relationship with them. How do I care about you? And this is what I have to do. Okay, and I don't know, I did make a few copies if you want to look on a bit, in case you can't read. If the font's clear enough, maybe we'll be okay then. But I'll leave them here and take reviews if you like. Thank you. This is the final core story, the whole model of the development of the ethical sensitivity from the nurse educators' contribution. So it's within that culture of teaching practice. Remember the uncertainty and all the hierarchies. Nurse educators enact that social mandate or service, and that's to care for the public. Okay, so it starts with, see if I can, will this, oh yeah, here we are. Okay, it starts with the nurse educator and the nursing student. I changed that, I think, to health educator on your handout. So they have that relationship that I talked about. It seems from the little tidbits of the nursing student study that I'm doing, they said they could always go to their nursing instructor. So it feels like it's a nice relationship. There wasn't one that, sometimes they couldn't go to their colleagues, but they could always go to the nursing instructor. Okay, so they're in this situation. They are getting a sense that something is not quite right. The awareness is starting to be triggered. It might be that gut feeling, or it might be, oh, I can't quite sleep, something's worrying me. And then they're going to do what they can to get a bigger picture of it. They realize, because of the complexity of the work environment, they can't usually just say something and act on it. They have to sort through all the loyalties that are involved. As I said, they're going to try and do what they can to enact that mandate for public safety and well-being. And in doing so, that usually would mean the student is safe for practice. However, if that doesn't happen or decisions get upturned, then the nurse educator is experiencing a challenge to the ethical ideals. That challenge can lead to moral turmoil or distress. And it doesn't stop there, though. The way forward was through reflection and having support. So they're going to keep reflecting on it. They're going to get support, and if they need broad range support, even counts, whatever they need, they're going to try and access it at that point, because as they get help and get more knowledge generated from the support and from the reflexivity, they're going to begin to transcend, get an even better picture, when that will inspire them to learn more and to grow. As they learn and grow, they are developing their phronesis. And that phronesis will come from both ways. It comes from doing what you can, doing a good job and meeting your social mandate to turn out, well-prepared students, or it comes from working through what didn't work, making changes, informing the practice, so that phronesis still happens. As I said, it's a virtue, so you build it through working in it, and then you bring it to the next situation. So that's a lot of this emerged when I did the concept analysis as a doctoral student. But what didn't emerge then, that's so exciting with the real stories, is that just that intense role of reflexivity. And I had it connected earlier with the gaining perspective. I actually didn't even call it that. I called that dividing loyalties. So now I was able to tease out the dividing loyalties and to show the different arrows, but it's that reflexivity that needs to be accompanied by support that is really quite critical. Okay, I'm winding down. So, yeah, as I said, if I could have listened to the tapes, I just would have maybe heard more with the pauses and the stories that would not have been ethical. And one of the participants actually coached the RA, said, you need to tell the next person that you're not a nurse, because they were using so much jargon and the student was just having such a hard time trying to sort things out, knowing what to pounce on. Okay, and I will go over some of these quickly because you're going to form some of your implications, and then, I'm going to be so happy to hear your questions. So nurse educators experience ethical dilemmas in both academia and in the practice settings where they take students. And I matched it up a little bit with the literature. As I said, I can make sure that you have a copy of the bib if you want to track down any of these. Nurse educators report experiencing moral turmoil more than distress, and it develops as a response to perceived irreconcilable, morally distressing events that challenge the nurse educators' ethical ideals. They couldn't fix the situation. They had to follow the institution's rules. There was no way to resolve the issue, and they did not feel they were making a difference. Ended up leaving the position, but not leaving nursing. Feelings of duty to society does not discourage the nurse educators from confronting academically or clinically unsafe students. And that was in contrast to Stokes, who's written quite a bit on sort of the ethical imperatives guiding nurses. They thought that they likely wouldn't fail them to respond to society's need because we need nurses. But this study, it was loud and clear, no, we can't have them. They were more in despair if a student that was unsafe actually had that decision upturned and was in practice. In this, okay. Yeah, and as I said, they didn't feel moral turmoil or distress with the student failing because that would not have enacted their mandate to care for the public. So once turmoil distress develops in the study, physical and psychological responses followed. The environment plays a tremendous impact on the development of moral turmoil distress. Program administrators play a significant role. They need to establish a culture that does not breed moral distress. And the educators were feeling unsupported, powerless, that their beliefs and values were compromised by decisions of university appeals committees. Withdrawal was a coping mechanism, and it's sad to read that. One said, I'm getting old, I'm getting tired, I think it's time to kind of pass the torch on to the new generation that's coming in. So, I hope I'll be able to support people as they're trying to develop themselves, but I don't see myself developing. Yeah. Again, another direction will be to tease out some of the burnout. And I loved having the actual qualitative data to go along with the more philosophical analysis. And managing the moral distress helps them to develop their moral self, strength, and empowerment. So it's that silver lining. You go through a horrible situation, and you become so much stronger for it. And those strategies, which I won't rehash now, the only one I wanted to talk a little bit more about was the reflexivity, because from the instructors themselves, they said, they would reflect, and that was the tool in their toolbox that they took out the most often. Some would reflect every night, and when there were students in practice, they'll have like a post-conference session where they process what happened during the day, and the students are developing their reflexivity. The goal is that the nurse educators were reflecting so much afterwards, reflecting on practice, that they got to the point where they could reflect while they were actually practicing that on the fly. And that's what Donald Schoen, who wrote Educating the Reflective Practitioner, calls as knowledge in action. And it's high level of professionalism to be able to do that. So it was kind of interesting that despite maybe not feeling prepared for this role, they learned how to become pretty high quality educators. And I think I have, in the support, I'm not going to rehash the support unless there are some questions. Yeah. Okay. self-transcendence was an important part. Like I can enact my leadership with this purpose and feel really good about it. In all of reading the transcribed interviews, what stood out was the commitment to and the pride in nursing. As I say, I would like to hear them because I'd like to hear the sparkle to their voice, because there were beautiful pieces where they were talking about wanting to strengthen the voice of nursing in all the education, in all the institutions. You know, I hope that I have a positive impact on others and that it made a difference in their life's travels and that they took a positive route, an easier route than the one they were on. You know, and I'm really trying to light a fire under the newbies, like passing the torch. I think that's, yeah. Okay, so working through ethical issues allows nurse educators to gain practical wisdom and strengthened resilience to carry forward to new situations. Such outcomes help them transcend morally distressing situations that would otherwise obstruct their enactment of ethical responsibilities to those they serve. So the moral turmoil and distress can make up a challenge and an opportunity, which might lead to increased introspection, team reflection, creative solutions, and opportunities for personal transformation and growth with sufficient support. Moral distress can also fuel accomplishment of professional goals, and it can make individuals more aware of and reflective about their own moral beliefs, strengthening their motivation to do better next time. Yeah, these could never do it. I never seem to get enough money, but when I put it together, it funds the projects, which is wonderful. Yeah, and there's, I don't know, 5 or 6 pages of references. So, questions? Did anything stand out that you wanted to ask about? Yes.
Maybe just you could speak more to the difference between moral turmoil and distress and how it is different.
Yeah, unfortunately, the moral turmoil arose from the nurse educators' own words, but more of them used that term. So it's not really a concept that's out there yet, except it seemed to be quite recognizable to and by them. But when they talk about the moral turmoil, their values are being challenged, and that's a lot of what they're talking about. And whereas with the distress, they see that as almost like a clinical situation where they have to leave, they have to take time off. Many times it would be on antidepressants or on, anxiolytics. So I think it's more a difference of severity, but as I say, the next little pot of money I get would likely be wanting to tease that out, because if we can catch it, if there's a phase before that we can all recognize and catch, maybe we can put more self-care.
I would like